Okay, so for today's lesson, we're going to be going over pregnancy. In my course, we call this Module 2, and it's going to cover multiple chapters, 4 chapters to be exact. I am looking just briefly at some fetal development concepts that you definitely need to know, and then we're going to cover chapters, so that's chapter 10. Chapter 11 and 12 are combined to look at the pregnancy and nursing care during pregnancy. And then in a separate video, I have chapter 19, which is the problems that you might experience in pregnancy. So let's get started. So in some courses, you might be required to memorize the stages of fetal development, and they're listed out for you here: zygotic, blastocyst, embryonic, and fetal stage. What I really want you to take away from this is that we describe pregnancies in trimesters, and so 12 weeks at a time. And as you become a professional working in this area, we no longer describe pregnancies in months. We talk about gestational weeks. And so you'll hear us say she's 34 weeks pregnant versus, what is that, 7, 6, 7-ish months. But if you need to learn more about the stages of fetal development, you can go here. For my course, it's beyond what we need to really know. This is just another picture looking at all the things that happen in order for that egg to develop and mature, be released, and then meet a sperm. And then as it meets that sperm and becomes fertilized, which is when the two groups of genetics come together, and now that is considered conception, and then it will move all the way over to the uterus, and we hope that it sets up in the top third of the fundus, which is the top of the uterus, but sometimes it sets up other places, and we'll talk about what that looks like. So again, this is just another picture of the ovary, the fallopian tube, and all of the pictures that I see most frequently make it look like these two things are attached, and actually they aren't. This is sitting attached by a blood supply and a ligament in the pelvis, and the uterus is also held up by ligaments. And then the fallopian tube is actually a little bit of ways away from the ovary, which is fascinating to me that it ever works out appropriately. So we're going to move on now. We're jumping ahead into pregnancy. We have a fertilized egg that is now implanted into the uterus, and we're talking about the placenta that develops from that area. It is really the interface between the mother and the fetus, and there are specific hormones that it makes to tell the mother's body, we're growing a baby now, and we need to utilize our nutrients differently. It is a protection to the fetus from immune attack. So being that interface between the mom and the fetus, it is the protection to keep the fetus from being attacked by the mother's immune system. It also provides immunity to the growing fetus and passively from the mother. So whatever the mother has antibodies to will be passed over to the fetus. It is the supply chain. So it brings all the nutrients from mother to the fetus, and including oxygen. And it also takes the waste products away from the fetus, and the mother's body then deals with it. So it's really a fantastic, amazing, disposable organ. And it is one of those organs that we're constantly learning more about. So I have the list of hormones here. This is a NCLEX style question. This is a memorization. When we are looking at a pregnancy test, we are looking for human chorionic gonadotropin, also called HCG. There are other hormones that the placenta also produces, and some of them in large quantities. Relaxin is one of the hormones that is produced along with the ovaries, and it is the hormone that tells all of the structures in the pelvis, the ligaments, and the collagen to relax to allow for a little more spread when that pelvis, when the baby is actually being born. So that's one of the reasons we get kind of that fluid walk in a pregnant person, because all that relaxin is in place. Prolactin is also a hormone related to pregnancy. It is produced in the pituitary, and it's produced a very small amount during pregnancy, but then there's a large surge of it when the placenta is expelled, because it coincides with this drop of estrogen and progesterone, and that is the hormone of milk production. So a lot of and we'll talk about this much later, but just because we're here, I'm going to mention it. A lot of the baby blues that we see right after delivery, that kind of overwhelmed, tearful, emotional feeling, has to do with these large drops of these hormones in a very short period of time. So here's that old placenta. This is the maternal side. This is the side that is attached into the uterus. And then this is the fetal side, which has the cord going to the baby. These are what we call cotyledons, and this is a really great picture of it. We want to look at it afterwards to make sure that all those pieces are actually intact, because if any are left behind, that can cause problems, and we'll talk about that in later lectures. Here is the sac that the baby actually grows in. So here you can see it's turned inside out. This is the cord that goes to the fetus, to the baby, and then this sac, there's actually 2 layers to it, and this is a fantastic picture of those 2 layers, amnion and chorion, and those, it's a very thick, tough sac, and that is what holds the fluid, the amniotic fluid, and the developing baby. So there's some podcasts again. They've done, Radiolab actually has done a really good series on the placenta. I learn things all the time. I like to tell my students we learn things in layers, and sometimes we do a deep dive into a specific concept and have a deeper understanding of it. For your purposes in this course, most of you are just trying to get through it, I understand, and you're just going to learn things at a very surface layer. But if you want to do a deep dive, these things are here to help you do that. So the umbilical cord is actually formed from the amnion. Remember, that's the 2 layers of that sac, amnion and chorion. It is the lifeline. So this cord is a very important part of developing and growing a healthy fetus. It contains 1 large vein and 2 small arteries. So there's a tip here. You can remember AVA or AVA, and then you can remember there's 2 arteries and 1 vein. It is filled with something called Wharton's jelly, which surrounds the vein and arteries to prevent compression. And once that hits the air, once Wharton's jelly comes out of the uterus and is in the atmosphere, it starts to harden. And that's what makes our umbilical cord belly button get hard and fall off after they're born. But something that could happen is if we have cord prolapse, where the cord comes down before the baby comes out, we don't want that to start hardening and cut off the blood supply to the baby. So if that situation happened, we want to cover that with a sterile soaked gauze as quickly as possible. At term, it can be anywhere, term meaning term pregnancy, it can be anywhere from 22 inches long and about 1 inch wide. Sometimes they're very short, sometimes they're really long, sometimes they have knots in them. So here is a very twisty umbilical cord, and you can see that very large vein. The vein is huge. And the reason that this vein is so large is because, contrary to the rest of what we've learned about our anatomy, it is the opposite in a fetus. So the vein carries the oxygenated blood and all the nutrients to the baby, and the arteries take all the waste products away from the baby. And this is a really important concept. You see this in NCLEX questions all the time. It's one of those things that you need to commit to memory. There's your 2 small arteries and a vein, and we do check to make sure that there are all 3 once the baby has delivered. if there is only two vessels, we are going to look a little closer for some specific birth defects that may come with that. Doesn't necessarily mean it is automatic, but we are going to look closely. And then this is actually a picture of taking a cord blood gas, which is similar to an ABG, arterial blood gas, except that, remember what I just said, we're looking at oxygenation in the vein and unoxygenation in the artery. So we do a cord blood gas, and that tells us at the moment of delivery, when that cord, we clamp it and send the sample off to the lab, labeling it very carefully. At the moment of delivery, it tells us about oxygenation. And sometimes we'll see this done in babies that have low APGAR scores. There's certain policies about why it needs to be done, but it's one of those snapshots in time to tell us how well the baby was oxygenating at birth. The role of the amniotic fluid is very interesting, and this was an aha moment for me recently, and I'll explain in just a minute. So it helps to maintain a constant body temperature. One of the things we do know is that the fetus is about 1 degree higher than the mom. So if a mom is running a temperature at her core body, that baby is about 1 degree higher. And we know if we get too high in temperature, our body systems can't achieve homeostasis, and we can't do all the things that our body systems need to do. So if a mom has a fever, we want to treat that so that we can save that baby from cooking on the inside. That's also the reason that we encourage women not to go into a hot tub or into a very hot bath or a sauna, because we don't want their body temperatures up too high. So the other role the amniotic fluid really serves is to permit symmetric growth and development. This is what the baby is moving around in, and it allows that sac, that amnion and chorion, to not adhere to the baby, and muscle development can happen. It cushions the fetus from trauma, and it cushions the umbilical cord. So here's a clinical judgment piece. If you have low amniotic fluid, we need to be concerned about the umbilical cord being compressed and not getting enough oxygen to the baby. So up until this year, I also thought that these babies would breathe in amniotic fluid, and they actually don't breathe it in, but it's the pressure of the fluid on the outside of them that maintains the pressure in the lungs that helps them to develop. They're actually not breathing it in. They do swallow it, but they actually are not breathing it in. And that was a total aha moment 25 years later. So this is a picture, a really great picture. This baby was born by a cesarean section, and you can see it in the sac and the fluid surrounding it, protecting that umbilical cord. And right after this picture is taken, I'm sure they open that sac because this baby now needs to come out and start to breathe. Here's another picture. And so we have about 30 mLs of amniotic fluid in the first trimester and approximately 1 liter in the third trimester. So these are just visuals to help you think about how much is normal, because we do have conditions of abnormal fluid levels that we will talk about in our next lecture. So fetal circulation, again, it's different when the mom and the placenta are functioning to help the processes for this fetus. So there are 3 shunts in fetal life: ductus venosus, ductus arteriosus, and foramen ovale. So you want to know the 3 and understand where they are, because it's kind of key to looking at a newborn transition and understanding the differences between fetal circulation and newborn circulation. And here is a picture. The ductus venosus bypasses the liver, because the liver doesn't really need to be used as a fetus, because the mom's body and placenta are managing those functions for the fetus. And then the foramen ovale is here shunting blood away from the lungs, because it is, again, not needed to, the lungs are not needed to oxygenate at this point. And the ductus arteriosus also participates in that. It has to do with the pressure inside the heart. But knowing that those are necessary to push to not circulate through the lungs at this point is as far as I need you to go. Now, all of this has to change as soon as the baby takes its first breath. And when we get to the birth lecture, we will talk about that. Inheritance, we're just going to briefly remind you, I know you've learned this in your prerequisite classes. When we're looking at genes, these are our individual units of heredity, and they are on a long strand of a chromosome, and it has continuous strands of our DNA, and that's what carries our genetic information. And we get half from our mom and half from our dad. So all together, we will have 22 pairs. I have to think about that. 23 pairs. This is the 23rd. That decides whether we're a male or female biologically. And so we get half from our mom, half from our dad. And so when we mix those two genes, we see what is created is a mix of those genes. So it is very common for the product of this union to look different than both of the contributors. There's some different patterns of inheritance. I'm not going to go too deeply here. Again, this is one of those things that we learn on the surface for this course, but you can definitely dive into this. It's entire degrees are based on this. There are different ways that we sometimes inherit problems and those can be exhibited as different disease processes, and there's different patterns of inheriting those issues. So there's lots of things that can go wrong in the replication of our chromosomes, and sometimes we'll see things that are monosomies or trisomies. And when we have this happen, it means that there is essentially an abnormality that happens with the chromosome. And there are a few of them that are well known that we see pretty frequently. One of them is trisomy 21, also, and that's showing what that picture is right there, also known as Down syndrome. Now, one of the more inclusive language ideas that I try to catch myself and say, instead of saying Down syndrome baby, we would say baby with Down syndrome, because it's still a baby. It just happens to also have Down syndrome. And so these are just some of the assessment criteria that we might see that lead us to think they might have this condition. And then we, of course, wouldn't say, we don't diagnose as nurses. And so we wouldn't say anything to the parents, but we would report to whoever the provider is, pediatrician, family medicine, physician, that we see some signs of potential chromosome abnormalities. Okay, so now we're going to move on into looking at maternal adaptation during pregnancy. And this is an important concept because NCLEX likes to ask this question. So when we're looking at signs and symptoms of pregnancy, we have three different types of signs and symptoms. We have presumptive, which is subjective. And so I like to remember the S means says. This is what the patient says is happening. Fatigue, breast tenderness, nausea, vomiting, amenorrhea, urinary frequency. So these are not definitive for pregnancy because they could be caused by something else. And then we move into, here are more presumptive signs: hyperpigmentation of the skin, breast enlargement and darkening of the areola, uterine enlargement, fetal movement, considered presumptive because quickening what the mom or birthing person says she feels. And then we move into probable signs. These are objective. So these are things that we see, that we can observe, we can see or feel. And then this is the list that fits in there. Goodell sign, Chadwick sign, and Hagar sign are all referring to signs we see in the cervix. Allotment, also signs we see in the cervix. And so I like to remember probable has the O in it, so it's objective, observe, see or feel. And then positive signs. These are your only diagnostic signs, and they cannot be caused by anything else. So ultrasound verification, we physically see it. We can hear the fetal heart tones, or we can feel fetal movement. So those other signs and symptoms could actually be caused by something else, including that positive pregnancy test, which is testing for which hormone? HCG. Good. As we go throughout the pregnancy, you're going to see changes in the uterine size. It goes from a pelvic organ to an abdominal organ. And about 20 weeks is when we see it at the level of the umbilicus. Now, it may be a little bit higher and a little bit lower in some people. Typically, by about the 3rd month, it starts to come up out of the pelvis and it becomes palpable. Breast changes throughout the pregnancy. We actually finish development of our breasts during pregnancy. And you're going to, for most people, they have enlargement of the breast and they have darkening of that areola. And then this is just a picture of how that uterus is changing. And this is what happens towards the end of pregnancy. You see all the organs, and all the organs have been pushed up out of the way to allow room for this fetus. So you can, now when we talk about some of those common discomforts we see in pregnancy, you can understand where they're coming from. So notable system changes. We have increased secretions in the vagina, that cervix, which is the bottom part of the uterus. I'm just going to go back so I can show you. The cervix is going to be right down here, creates a mucus barrier to try to protect from bacteria getting in there. There's decreased peristalsis, which makes total sense because everything is squished, and decreased gastric emptying, and increased smooth muscle relaxation. So what do you think all of this might lead to? And if you said constipation and potential hemorrhoids, that is true, especially because we're asking these patients to take extra iron, and that can cause constipation in some people. So just something to have in the back of your mind when you're starting to apply your clinical judgment. We have about 50% more blood volume. There's increased venous return, increased heart rate, and increased plasma, which creates hemodilution. So we often see lower levels of circulating iron because we have a greater volume of blood. And so we call that the anemia of pregnancy. So increased iron demands. We're also hypercoagulable, which it makes sense because she's going to be delivering and there's going to be some blood loss. And so the body creates a hypercoagulable state, which puts women at higher risk for blood clots and other cardiac issues, especially if they already had them. And then increased oxygen consumption. And a lot of women complain about increased congestion, and that's from the increased vascularity. There's increase in your GFR, flow and volume. There's that softening and stretching of those ligaments, a shifting of the center of gravity. So that makes it more likely that a woman can have a fall because that center of gravity is different. We see lots of different changes in the skin, hyperpigmentation, stria gravidarum, also known as stretch marks, and varicosities. And overall, the immune system is dampened down a little bit because it's the body's way of protecting the fetus. So we don't want the woman's body to respond to this fetus. And so the immune system is lessened a little, and that puts pregnant women at high risk for infection. So looking at our nutritional needs, I like to tell moms that what you eat is what your baby's going to be made out of. So there's a direct nutritional effect on the fetus from intake. There is an increased need for vitamin and mineral supplements. And so we're looking for an increase in protein, iron, and folate specifically. Folate is what we get from foods, and folic acid is what we take. And actually, folic acid is absorbed a little bit easier. So we do recommend folic acid in pregnancy. There is a USDA has a food guide, which is called My Plate. I have a picture of it coming up. And we do want to talk about some of the foods that need to be avoided. Um, Very high bacteria foods, because remember, her immune system is decreased, and some fish that contains high mercury. And there's a whole list in your textbook, and you should probably take a look at that. Here's that My Pregnancy Plate. And looking at maternal weight gain, knowing that, especially in modern day society, this is a very sensitive topic to a lot of women. Another aha moment for me is the whole idea of BMI. When the BMI calculator was created, it was looking at populations, not individuals. And so it's really a poor individual assessment. And there's a growing body of research that says your BMI is not necessarily directly related to how healthy you are. I'm going to say that again. The BMI is not necessarily directly related to how healthy you are. So a low BMI or a high BMI is not necessarily directly related. And so I do think that we might see some changes in that in the next few years, but for our purposes today, this is what we're looking at. This is standard of practice. We're calling a healthy weight BMI. If you are at 25, if your BMI is 20, less than 25, we are going to expect a 25 to 35 pound weight gain. And it might not be linear like this. You might not see it exactly laid out in as the trimesters are listed here, but we're looking at for an overall 25 to 35 pound weight gain. If the BMI is less than 19 or underweight, we want a little more weight gain, 28 to 40 pounds. And if the BMI is over 25, we want a little less weight gain, ideally 15 to 25 pounds. Again, this is what our current research tells us, but I am suspicious that this will change. Here are the take-home points about nutrition. They need about 300 to 350 calories per day over the pre-pregnancy diet. Protein, we need to increase that protein, and it does not have to be from animal sources. There are other ways of getting protein. Iron is about 30 milligrams per day, calcium about 1,000 milligrams per day, DHA, fiber, and folic acid. If a woman is in a low risk category, she's going to need about 400 micrograms. If she's in a high risk category, she's going to need about 4 milligrams. And the thing that makes them different categories is if they have certain components, if they have the I always say the wrong MTHFR gene, and or if they have had a baby with a neural tube defect, then they're in the high risk category. And interestingly enough, a good quality prenatal vitamin has all of these things in it. Now we're going to move on to nursing management during pregnancy. And ideally, women will come for a preconception care visit. They're seeing their provider. Maybe they've been using birth control and they're ready to now think about getting pregnant. And what we recommend is that if someone is trying to get pregnant, they should act like they already are. And so what that means is taking that prenatal vitamin, being sure that you get enough folic acid before that pregnancy happens, avoiding alcohol, avoiding other drugs, avoiding smoking, all the things that you getting enough rest, getting enough exercise, all the things that you will do when you're pregnant. Hopefully, we would like you to start before you get pregnant. And then once you get pregnant, we, interestingly enough, pregnancy starts on the first day of your last menstrual period. So obviously you're not pregnant on the day that you have your period. It's actually about 2 weeks that we count in your pregnancy that you're actually not pregnant. Most women ovulate somewhere around the 14th day or so. And so those first 2 weeks are not pregnant, but this is how it's always done. First day of the last menstrual period is day one. And so there's something called the all or nothing concept or all or none concept. And so in those first couple of weeks, whatever substances or toxins or teratogens, that's the word you need to know, that the woman is exposed to, it's either going to be catastrophic to the fetus or have no effect. And we don't know exactly what day those things happen. We know that it's about weeks 1 through 4. And I'm not going to go too deeply into why this is. We just know that sometimes women didn't know that they were pregnant and maybe weren't acting like they were already pregnant and are exposed to something, and it will either have no effect at all or a catastrophic effect. And that's one of the things that we as nurses and when we're giving good education can reassure them that it doesn't necessarily mean that it was all terrible. So our first prenatal visit is really about establishing trust and doing a lot of what can you expect in the next few weeks, and hopefully encouraging her enough to come back and be seen. Our goal of all prenatal visits are detection and prevention of potential problems. We're going to be doing a comprehensive health history, physical exam, and some lab tests. We want to know about her surgical history, her reproductive history, her gynecological history. And remember, trauma-informed care encourages us to ask and then tell her why you're asking before you just start with all the really personal questions. Sometimes people don't understand why we have to ask all of these questions. And if they understand, they're more apt to tell us. We are looking at her menstrual history as well. And then we're going to try to calculate her due date. Now, I teach you about Miguel's rule here because it's a really quick method, but there's only certain times it can actually be used. So if the person got pregnant while on birth control or does not have regular 28-ish day cycles, Miguel's rule is not going to work. But we will take the first day of his last menstrual period, and I've given you an example here. You're going to subtract 3 months from that, and then add 7 days and 1 year, and then that is the estimated due date. Now, we can be far off from this, and when we do the ultrasounds, most people do get ultrasounds early on, and then again at 20 weeks for an anatomy scan. We may find big differences, and that date may actually change based on that. I want to point this out. Early ultrasound is the best method of dating a pregnancy. But NCLEX loves to ask you about Miguel's rule. So make sure that you know how to do this calculation. So you'll see terms sometimes, EDB, date of birth, or expected date of delivery, or expected date of confinement. That's an old term back from the colonial times. These are modern day ways of determining a due date. You can either use a due date calculator on an app, or sometimes in ERs or other outside areas, you'll still see wheels. We use wheels in labor and delivery all the time. And you will put this arrow on the first day of the last menstrual period, and then you find the date of where you are today, and it will give you an approximate of how many weeks she is and an approximate date of delivery. Now, that 40 days is not set in stone. It's not a contract. We really should be giving them a broad range of about 3 weeks of when to expect this baby coming. So you might say mid-September rather than this exact due date. But in our society, we've gotten real caught up on that actual 40 weeks. So here's some terms that we're going to go through when we're talking about gravida. Gravid is a pregnant woman, or gravid uterus is a pregnant uterus. Gravida 1, prima gravida, is first pregnancy. Gravida 2 or beyond, multigravida, is a second pregnancy. And in labor and delivery, we tend to shorten everything up and make our own slang. So you'll hear primi or multip, and those are terms referring to how many pregnancies a woman has had. So gravida is how many times you've been pregnant. Para is how many times a woman has produced a child after 20 weeks. So gravida para is how many times you've been pregnant, how many deliveries you've had. And so here are just some terms along the bottom that you can see how we use those. And that is explaining exactly what I just said. Then there's another way, and you'll see this in prenatal records, of us breaking it down a little bit more. And this helps the provider to understand a little bit more about the obstetric history. And I'll tell you why in just a second here. So Gravida, again, including the current pregnancy, and then a term that, so this is what we call the GTPALM. There's the GTPALM system. So the G is still Gravida. The T is how many term births you've had. The P is how many preterm deliveries. That is before 20 weeks. I'm sorry, after 20 weeks, but before 37 weeks. So preterm births. The A is for abortions. Now, let me just stop here for a second. Abortion is a term of a pregnancy that does not result in live birth. So it is miscarriages, which is the commonly used term, or abortions that were therapeutic, that were chosen. So we don't use the term abortion to women when we are talking about miscarriages because they only know of the one term for that. So abortions are the number of pregnancies ending before 20 weeks, and then living children, number of children that are actually living, and our M is for multiples. So in this example, I have a Gravida 3, Para 2, so this would be a term. And so this Gravida 3, she's been pregnant 3 times, she's delivered 2, and that she's still pregnant with the other one. She's had no preterm deliveries. She's had no abortions. She has 2 living children, and then there are no multiples. Usually we leave the M off if there's no multiples. So this really should be a T. Okay, so now we're going to move on to the physical assessment. Head to toe, you already know about that. A few things are going to be a little bit different. We really want to look at the vital signs and get a good baseline. So to take a proper blood pressure, legs aren't crossed, appropriately sized cuff, not talking while she's doing it, not the first thing you do when you come into the doctor's office, because some people have white coat syndrome and their blood pressure is a little higher. So we want to make sure we get a good baseline of those vital signs. And then another aha moment. I've had a lot of aha moments this year. I'm teaching, so let me backtrack for just a minute here. When we're talking about pelvic shapes and sizes, this has been taught and it is still in your textbook, that is still in your textbook today. There was a article that was put out in 2021, and they basically implored us to stop teaching this classification system of pelvises because it is based on racist ideology. The challenge I have is that you may still see it on your NCLEX exam, you may still see it on your ATI exam, and so it's going to be a while until it's taken out of those national standardized tests, right? So I have to still teach you what they're looking for, but I want you to understand that we are going to take this out of the textbooks. This is not based on science. And so when you're looking at, I'm going to teach it the old way. They classified the different pelvic shapes and said that certain pelvises have a more likelihood of having a vaginal delivery or not, and that is the gynecoid pelvis. And these others, you can still have babies through them, but sometimes it's a little more difficult. The caveat is we don't always know what type of pelvis you have. There's not an easy way to determine what type of pelvis you have. And you might have something else in your history or in your genetics that just changes the shape of your pelvis. So again, this has got a red circle around it because we're only learning this for NCLEX purposes. We recognize that all shapes and sizes of pelvises can deliver babies, and that all people from different ethnic backgrounds have all different shapes and sizes of pelvises. Okay, prenatal labs. This isn't where you need to spend some time. If you have not done it already, or if you are using the guided notes, you're going to want to get out your guided notes and list out all of these prenatal labs. And you need to know what is the desired result. What are we looking for? Like, do we want the rubella titer to be positive or negative? I'm going to give you a hint. We want it to be positive because we want them to be immune to rubella before they get pregnant. Rubella is one of those, measles, mumps, and rubella is where we typically see this vaccine. And it is one of those modified live vaccines or live vaccines that we cannot give in pregnancy. Now, why can't we give a live vaccine in pregnancy? We've already talked about this. And that's right. It's because her immune system is suppressed. And if we give her a live vaccine, we could actually infect her with that disease. So live vaccines are out during pregnancy. So go through each of these and have a clear understanding of what they are, what the desired result is, and what are we going to do about it if she does not have the desired result. Same thing for a UA. So this is a urine dip, and we used to use these quite a bit at the bedside. Some places may still use them at the bedside, but most places are sending them to the lab to have the UAs run now. But understand what it is that you see in a UA. When you are dipping urine, these little squares are all related to this little square on the outside of the bottle, and you're going to match the color to the square to determine what your result is. So this is why they send them to labs, because they're a little more precise, but you can still get a good idea. If she's spilling a ton of glucose, you can see that on a urine dip. And just so you know, in pregnancy, it is not uncommon to see a little bit of ketones, to see a little bit of protein, and maybe even see a little bit of sugar. But we shouldn't see high levels of those things. And know what it means when you have leukocytes. Know what it means when you have nitrates in your urine. Okay, follow-up visit. We want to see her every 4 weeks up to the 28th week, every 2 weeks after that, and then every week until birth. In our follow-up visits, we're going to be doing weight and blood pressure. And remember that weight is a sensitive topic, so you're going to ask, do you want to know about your weight gain, or would you rather me just write it down and not tell you? And some women, especially those that have a history of eating disorders in their background, or disordered eating, they don't want to know what their weight is. We're going to be testing that urine. Here's a hint for things like protein, glucose, ketones, and nitrates. Make sure you know why. We're going to be measuring a fundal height. I'm going to show you about that in just a second. We're going to be feeling for fetal movement, asking about fetal movement, and listening to the fetal heart rate. And then most importantly, we're going to be teaching danger signs so she knows when she needs to call back, even if it's before that next scheduled appointment. Measuring the fundal height is going from the symphysis pubis up to the top of the fundus or the xiphoid process, whichever one is lower. So we want to go all the way up until we feel the top of the fundus, which is where the top of the uterus is. And when we measure this in centimeters, it closely resembles the amount of weeks she is. So see how I said at 20 weeks, you'll measure about to the level of the umbilicus, and then 24 weeks, 26 weeks. And so this is a great way, if you have someone come in with a pregnancy that has been undated and you don't have any idea how far pregnant she actually is, you can do a quick little check. Is it above the fundus or below? I mean, above the umbilicus or below? And that can determine where she gets seen. Most hospitals or facilities, if you're under 20 weeks, you're going to be seen in the emergency room for whatever your problem is. And if you're over 20 weeks, you're going to be seen in the labor and delivery unit. And that has to do with viability of the fetus. So here is how you would actually measure top of the pubic symphysis to the highest part of the uterus, or to the xiphoid process if it goes up that high. This is Leopold's maneuver. This is not something that you have to know how to do, but I just want you to know what it is. Sometimes you'll see questions related to that. Leopold's maneuver is a way of helping us determine where the baby is inside that uterus. And there's certain steps that we walk through in order to determine that. It helps us determine if the baby is head down, and sometimes even what direction the baby is facing. And here are those warning signs. You're going to want to commit these to memory. At this point, you don't know why these are warning signs, but as we continue through the course of the next couple of weeks, you will know why they're warning signs. But for now, I just want you to know visual disturbances is seeing spots or feeling like you're losing your peripheral vision, or everything getting dark on the sides, or seeing sparkles in front of you. Headache is a headache that doesn't go away with Tylenol, usually a persistent frontal headache, severe edema, especially around the face or eyes, but severe edema anywhere needs to be addressed. Rapid weight gain is usually related to edema, so we say more than 5 pounds in a week. Pain, we're just going to say if you have unusual pain, that's a warning sign. Signs of infection, vaginal bleeding or drainage, persistent vomiting, muscular irritability or convulsions or feeling jumpy, or absence or decrease in fetal movement once it's been felt. All of these need immediate assessment. And so that means you can't wait until your next doctor's appointment. You don't wait until tomorrow when the doctor's office opens or midwife's office opens. These are reasons to seek urgent care or ER assistance. So now we're going to look a little bit at fetal well-being, beyond the scope of this course to really understand all the different things that we're looking at to assess fetal well-being, but a few that you should know. Ultrasonography, doing a 20-week ultrasound, usually for anatomy, they call it anatomy scan, is pretty common. There are several different types of genetic screenings, but they're based on how many weeks you are. Some are done in the first trimester and some are done in the second trimester, and all of them are meant to determine if further testing needs to be done. So these are screenings, not diagnostics. So if a screening, for instance, if the maternal alpha fetal protein screen is done in the wrong timing, it can actually screen positive when it's not positive. And so these are looking for neural tube and trisomies. And then we have some non-invasive prenatal testing where they will draw mom's blood and do some ultrasounds. And then amniocentesis, which is what you see the picture of here, is the most invasive. It does carry some risk with it. Remember, we look at absolute risk versus relative risk. There are some risks associated with it. And this is when they actually take some of the amniotic fluid out and test that amniotic fluid. So this would be diagnostic. And this is just a picture of some of the ultrasounds that we can do nowadays. These are some of the 4D ultrasounds. And non-stress tests. You have a whole lecture on fetal monitoring, but there is something that we're just going to mention here. Our non-stress test is a specific test to give us a snapshot of time, of that exact time of how the baby is oxygenating on the inside. So what we're looking for is the test positive or negative. So a positive non-stress test, make sure I'm saying this right. So we're looking for reassuring or non-reassuring on a non-stress test. So if we have accelerations and good variability in the fetal heart rate and no decelerations, then we are reasonably assured this baby is well oxygenated at that point in time. And so that's what we're looking at when we do a non-stress test. And it does require someone that has been trained in fetal monitoring to be able to assess. If we do a non-stress test, let's say we have a mom that comes in for decreased fetal movement, and we do a non-stress test and it's non-reassuring. We don't see good variability or accelerations above the baseline or a normal baseline rate, or we have decelerations. We're going to send her for a further test, which is called a biophysical profile. And so now they're going to look with ultrasound and they're going to give a score and determine if that snapshot in time, if the baby is showing signs of hypoxia. And so you can look here and read in your book how the scoring system is done, and be sure that you know the numbers that you would need to intervene. So the scoring system can go all the way up to 10, although typically it stops at 8 because the last 2 points are for your non-stress test. So it goes all the way up to 8, we'll say. And if you get a score of 6, what is the recommendation? If you get a score of 4, what is the recommendation? Take a look there. We're going to talk about some of the common discomforts because we have to know what's normal in order to know what's not normal. And so urinary frequency or even a little incontinence is an expected first trimester discomfort. Now, we do want to make sure that we rule out a potential UTI if she has other symptoms, but the increased pressure of the uterus on that bladder can cause some of these things. A little bit of bleeding gums, a little bit of nosebleed. Remember, she's got increased vascularity, so that is not uncommon. Constipation, there it is. That is not uncommon in our first trimester. Second trimester, backache, varicosity of the vulva or the legs, hemorrhoids, increased flatulence. Again, that's because this little one is taking up a lot more room and things are having to move out of the way. Now, this is a picture I put here specifically because as this uterus starts to get bigger with a growing fetus, if a mom lays flat on her back, she can potentially cut off the circulation to her own inferior vena cava. And what kinds of some signs and symptoms do you think she might exhibit if she's cutting off that circulation? She might be lightheaded. She might feel like she's going to pass out. She might have a feeling of doom. She might feel heaviness in her chest. She will have a desire to get off of that vena cava. And that is the fix. Turn her a little bit to her side or all the way over to her side. Sit her up. Get that fetus off the vena cava and she will feel better. That's called vena cava syndrome, by the way, or supine hypotension. So this is why we don't want pregnant women laying flat on their back. Third trimester discomforts, we see a lot of the return of the first trimester as that baby settles down into the pelvis, sometimes shortness of breath, heartburn, indigestion, dependent edema. It is not uncommon to see dependent edema. What we don't want to see is edema, like I mentioned before, around the eyes, called periorbital edema, around the face, extreme swelling in the hands. That is worrisome and needs to be looked at, but dependent edema, pretty common. So we want to promote self-care with good prenatal education, right? With these kinds of things that we want to cover with our patient. Dental care, very important to have good dental hygiene during pregnancy because we know some bacteria in the mouth is actually a potential trigger for preterm labor and preterm delivery. Exercise, if they were avidly exercising before pregnancy, they can continue that as long as there's no issue, but it's probably not the time to become a marathon runner. Sexual activity can continue unless there's bleeding or leaking of fluid or preterm labor. Employment, she can continue working just with the mindset that her center of gravity has changed and she might experience some increased dependent edema. And then immunizations. Immunizations in pregnancy are going to increase that passive immunity over to the fetus. So we want all mothers in the third trimester to get a Tdap vaccine. And that's for that pertussis that's in the vaccine, because then that referred immunity transfers over to that baby who will not be able to have that vaccine for many, many months after delivery. Influenza, one of the the population with one of the highest rates of hospitalization is pregnant women with influenza. And so getting a flu vaccine will also refer some of that immunity, protect the mom and refer some of the immunity to the fetus. And then COVID-19 is recommended as well. And if you have questions about that, you can check out the CDC website. And then other topics that we would want to discuss with her when she goes to childbirth education, she's going to learn a lot of things. Remember, I said in a previous video, it's not just about how to deal with the pain, it's about what's happening. And also the hospital routine. So it's nice to have those classes that are offered from their hospital. Also looking at baby basics, caring for this baby once you bring it home, breastfeeding if that's her choice. So there's lots of good topics to be provided in education. Feeding choices, it really needs to be decided in pregnancy. And then when we are giving information, remember we're going to use shared decision making. So with breastfeeding, we're going to talk about advantages and disadvantages. And with bottle feeding, formula feeding, we're going to talk about advantages and disadvantages, because sometimes you will give breast milk in a bottle. So we want to talk about all of it and help them have the tools they need and the resources if they have problems or need further information. And so here are some benefits of breastfeeding for both mom and baby. And this is my new favorite photo. This is a real popular picture nowadays. I don't know who this is. I just found them on the internet, but as sweet as she can be, is they have them, they're actually laying down, but they look like they're sitting in a swing. And I absolutely love them. If you've been in any of my courses before, you know that we didn't take pictures like this of babies when my babies were small, and I pine over these pictures. Anyway, thanks for listening, and the guided notes will be in the description.